Hey guys, I wanted to try to make a video on sepsis because we've had a couple of fallouts and I think it's something that we can definitely improve our knowledge of. We have a lot of you that are new and I want to make sure that you guys understand why we focus so much on the different parts of sepsis and treatment for sepsis. I taught a class 3 years ago on sepsis. It was a long 3-hour class. That's where these slides are coming from. I'm gonna try to keep this down to like less than 15 minutes. Um, but hopefully you'll get enough out of it. Okay, so the objectives are we want to make sure that you understand the why behind our focus on sepsis, how to identify potential septic patients, to anchor the current sepsis process, and ultimately save lives. And I will tell you that as you will see in some of these slides and presentation, you will understand why it is so crucial that we follow these parts for sepsis. It actually does make a difference in our mortalities. 6% of all inpatient hospital admissions are diagnosed with sepsis. That doesn't seem like a big number, but when you look at the number of people that die in a hospital from sepsis, it's 1 in 3. So even though it's only 6% of people in the hospital that are admitted for sepsis, 1 in 3 of the patients that die in the hospitals die from sepsis. This chart shows you on the blue side the occurrence of sepsis compared to other diagnoses. You can see that it's more than colon, breast cancer, and AIDS combined, and it's a lot more than CHF also. And then on the yellow side, this is the mortality, and acute MI beats sepsis just by a tiny little bit. But these slides are old, and it's actually surpassed acute MI in the last few years with COVID. So sepsis is definitely one of the biggest drivers of mortality in hospitals and in the community. There are some people that died from sepsis. I don't know some of them. That middle guy, he was in some rock band, I think. Okay, I love this chart. If you look at the left side, it tells you on the top the percentage of people that survived sepsis. So on the left side, 82% of people, and on the bottom is the time from the onset of septic shock to the time they receive the appropriate antibiotics. So if you arrive in the hospital and you're treated with the right antibiotics within 30 minutes of you acquiring septic shock, so let's say that you're a patient on the floor and somebody identified by spot alert that they're in septic shock, their blood pressure is tanking, and we can give them those antibiotics within the first half hour, they have an 82% chance of survival. But look at how dramatically that percentage chance of survival drops. So let's say that somebody was feeling horrible at night and they didn't call a rapid and their blood pressure was dropping all night. They called the hospitalist gave them a little bit of fluid, and maybe they drew a lactic at some point. And finally, 6 to 9 hours later, they call a rapid and we go out there and we get them back here and we get them antibiotics. 32% chance of survival for those patients, and it keeps dropping after that. Imagine in a nursing home, somebody who's been sick all night and the nursing home thought they just had a virus or something, and the patient has been in septic shock for 12 to 24 hours or a little more than 24 hours. They have a less than 10% chance of survival. So it is very deadly to go into septic shock. Shivering, extreme pain, paler mottled skin, sleepy, difficulty arousing, feel like I might die, short of breath. Those are the different signs of sepsis. One of the main reason why people go into shock, of course, is because of what happens to your blood vessels while you're septic. Basically, normally your blood vessels, all your cells are really close together, so they keep all the fluid and the cells inside the blood vessels. When you're septic, you vasodilate. So this happens for different reasons. In the beginning, it happens because your body wants to deliver fluid and antibodies to the infected site, and it delivers it through the circulatory system, and then it becomes permeable and it leaves in that area. But once you're overwhelmingly septic and that vasodilation happens in your entire body, now your body can't contain fluid inside your vascular system in your pump. So all that fluid leaks out and you're left with just your blood cells. So you have to resuscitate with fluids. This is why septic patients need so much fluid. Sometimes they need, 5 to 6 liters in the first 6 hours, or more in the first 24 hours. I've seen somebody with 30 liters over in a span of 24 hours. And this is why. This is just a picture of what ARDS look like on a patient with sepsis. Complications, of course, I won't go into big detail. You guys know what shock is, but septic shock is distributive shock, as we talked about, is because of the inability to provide oxygenation to all the organs. So it's not being distributed the right way. And how does it lead to shock? Well, I don't know if you've seen this chart before. It looks, it's basically what they use in the ER to meet all their bundle compliance. I'm going to kind of go through it kind of fast because I don't want to take a lot of time, but this is how you escalate from just having SIRS, which are systemic inflammatory response syndrome markers, all the way to septic shock. These are the SIRS. It's a white count of less than 4 or greater than 12,000, or bands greater than 10%, temperature greater than 100.9 or less than 96.8, heart rate greater than 90, respiratory rate greater than 20. If you have 2 of these, this is a sign that you may have sepsis, okay? Now, it doesn't mean you have sepsis, because if you come in an AFib and you're anxious and you're breathing more than 20 times a minute, you're going to have 2 SIRS, but you're not going to have sepsis unless you have a source, which is where the next slide comes in. 2 SIRS plus a suspected or confirmed infection, that is sepsis. These are the different types of infections, but you have to have the SIRS and the documented type, the documented or suspected confirmed infection. When they call you a spot alert and you do your sepsis screening, this is what it's looking for. Okay, so now severe sepsis is they met the sepsis criteria, plus they have at least 1 organ dysfunction. And these are the different organ dysfunctions: systolic blood pressure less than 90 or MAPA less than 65, lactate greater than 2, acute renal failure, urine output less than 0.5 mLs per kilo per hour for more than 2 hours. If somebody has to go on BiPAP and they have sepsis, they have met sepsis criteria, they're now severe sepsis. Platelets less than 100,000, INR greater than 1.5, or PTT less than 60 seconds or more than 60 seconds, bilirubin greater than 2. Now, after severe sepsis, here comes the bad one. This is septic shock. You're going to have sepsis criteria plus 1 of the following. Either your lactic is greater than 4. Notice that for severe sepsis was greater than 2. Hypotensive, and this is persistent hypotension. Severe sepsis is just hypotension that may reverse itself with fluids. This is hypotension that is consistent, and now it's probably going to require pressors or continuous boluses. So that is septic shock. And oh God, what are we going to do now? Okay, well, we're going to tell you what we're going to do about those patients. We're going to give them a 30 ml per kilo saline bolus. Make sure that the doctor completes their sepsis reassessment. This is part of the documentation. They do it automatically. And you're going to maximize their fluid resuscitation either using the EV1000 or clinically by looking at the patient. You don't want to start pressors until you've maximized their fluid resuscitation. What is SPOT? SPOT stands for Sepsis Prediction and Optimization of Therapy. It was created by HCA. It has saved hundreds, if not thousands, of lives by identifying patients with their SIRS criteria on the floor, and then you get an alert. This is why you have to respond to the spot alert in real time. You should not wait till that 59 minutes to assess your patient for sepsis. You're going to have somebody that has SIRS. Now you got to go in there and say, do they have a source? Is there something that I'm missing so that this patient triggers positive for sepsis? If they trigger positive for sepsis, then you need to notify the doctor, and then they'll determine whether they're in severe or septic shock. What are the expected treatments? I'm not going to go through every single one of these. The most important ones here: measure lactic acid with repeat checks every 4 hours until it's less than 2. Make sure that you're using the EV1000 to maximize your fluid intake for the patient before you start your pressors. Get blood cultures times 2 prior to the administration of antibiotic if possible. Please, 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 never, ever, ever withhold antibiotics simply because you have not been able to get your blood cultures drawn. Antibiotics should be administered in the first hour, regardless of whether you were able to get blood cultures or not. We want to try to get those blood cultures before the antibiotic, but we are not going to wait more than 1 hour to give the antibiotic. If it's been 45 minutes and they haven't drawn your blood cultures, get ready to give your antibiotics, have them hung, have them ready to go, and start them before the hour is up. This is what's going to save their life. As far as the lactic, if the initial is greater than 2, it's going to reflex. It's going to reflex 2 hours from the result. I know that's weird, but that's because let's say that you drew them at 1800, you got the result at 1900. It's going to tell you to draw 2 hours after that, which is 3 hours from the initial draw. I don't want you drawing it then. I want you to wait closer to the 4-hour mark. We don't want to draw them more often than every 4 hours. Sometimes if the doctor doesn't understand how it's reflexing, they might order an extra lactic. So you might have some off-time lactic orders. I want you to forget the lactic order time and concentrate on knowing when your patient's last lactic was drawn. If you drew it at 1800, the next one is due at 2200. This is why it's so important to get the time from the ER that they drew the initial lactic. You have to know that time, because when the patient gets up here and it's been 2.5 hours, you know that you have an hour and a half to draw your next lactic. It has to be done before the 4-hour mark that first time to meet the criteria. After that, it needs to be every 4 hours. If you're off by a couple of minutes, it's not a big deal. But please, please, please don't go by the time that the label or the order says. Go by the actual time where they were drawn. 4 hours from each draw. That is when they should be done, until they're less than 2, or until the doctor tells you they don't need any more because maybe the patient is not septic. Okay, so we already did all that. Treatment goals. The main goal, correct decreased tissue perfusion. I can't say it enough. Always maximize your fluids on your patient before you start your pressors. You don't want to delay pressors for more than, I would say, 3 to 6 hours. But if your patient is responding to fluids and your stroke volume tells you that the patient is still dry, continue to give fluids before you start your pressors. And even after your pressors, you need to continue to administer fluids so that the patient doesn't become dependent on the pressors and now you're causing more harm than good. Levofed does not work when there is nothing for it to pump. If you have a patient that you have fluid optimized and you start Levo at 0.05, their blood pressure will go up immediately. If you have somebody and you have to start them at 0.5, you know that that patient is not fluid optimized and they need fluids. Also be careful if a patient's on beta blockers because it might be masking their heart rate. And that's something that you have to just keep an eye on. Make sure they have good venous access. They might need a central line, especially if they're going on pressors. Don't be afraid to give them fluids. Some patients in CHF or renal failure, a lot of the doctors will be a little more reserved than giving them fluids, but the literature says that they should give the full resuscitation level of fluids regardless of if the patient ends up being intubated or if the patient needs dialysis later, because they are not going to survive if they don't resuscitate them with fluids. You all know what MAP is. Stroke volume, we'll just talk a little bit about this. You should know how to do these. And if you haven't taken the hemodynamics class, please sign up for the next one. It's, I think, in January or February. We'll put it on the out there. It is the best class that you're going to take and the one that's going to teach you the most. And they will teach you how to do a fluid challenge and a passive leg raise. But basically, if you do a bolus and their stroke volume increases by more than 10%, it means that the fluids are affecting the patient. It means that they are dry and they need another bolus. You will continue to do the 250 ml bolus until the stroke volume does not increase by 10% or more. So if the patient's baseline is 44, you give them a bolus and it went to 60, you know that it went up by more than 10% of 44, which would have been 4.4, and they need another bolus. So you continue to do that until it stops going up by 10%. Okay, I've already talked about all this. Sometimes also these patients might need a blood transfusion. You might have a patient who has an okay blood pressure, but their hemoglobin is 7. These patients might be getting blood flow to their organs, but there's not enough oxygen carrying cells to really perfuse and oxygenate these organs. So the lactic acid will continue to increase because lactic acid is formed when your organs are not being perfused or oxygenated. So even though you might have a patient with a good blood pressure, a MAP of 68, if their hemoglobin is 3, you are not perfusing those organs enough. There's not enough oxygen getting to them. So keep that in mind. The other goal, other than correcting volume optimization in your patients, is to correct the hypoxemia. Make sure that they're getting ABGs, that they have the appropriate oxygen, monitor the pulse ox, and tidal CO2, very important. If you have anybody that comes into the hospital that need to be put on oxygen and they weren't on oxygen before, and they are not at their baseline mental status, those patients should be on capnography. Because it happens every day in the hospital. You have somebody on the floor that for the last couple of days has been a little bit obtunded. They're on 2 liters, satting 100%, and the nurses just think that they're just not feeling well. And then we see them in a rapid response 2 days later, and their CO2 is 120. So capnography, very important for these patients. So that's pretty much all the information. I'll end by saying this, and I'll do a quick recap. If you have a patient that all of a sudden has left-sided weakness, what do? You immediately panic. You immediately call the doctor. We call a stroke alert. We take them to the CAT scan. We give them TNKs, and we hopefully save them from having a devastating stroke. Same thing with chest pain. We get an EKG right away. We get troponins. We give them nitro. We get them to the cath lab. Sepsis kills just as many people as heart attacks and more people than stroke. So why is it that we don't focus so much on it? It's not as sexy as heart attacks and strokes? I don't know why, but hopefully this video will get you to think about sepsis a little bit different, because it is the #1 killer in our hospital. 1 out of 3 patients that die, again, they die of sepsis. So please take that to heart. And just to recap really quickly, lactic acid every 4 hours, if it's greater than 2. Don't concentrate on the order time. Concentrate on the time that you drew the last lactic or the ER drew the last lactic. And until the doctor tells you to stop, you're going to continue to reflex those lactics. Always fluid maximize your patient before you start your pressors. And once you started pressors, don't forget, these patients are going to continue to need fluids. So if you're having to titrate your pressors all the time, and you haven't been given boluses, or maybe they're just on like 50 mLs of D5 half with 20 of K, ask the doctor for some fluids, because most likely these patients are dry. All right, hopefully you guys get something out of this video. And if you have any comments, please put them in the comments on the video so that we can talk a little more about it. Thank you.